Welcome. In this session, we'll cover multiple sclerosis, one of the most important neuroinflammatory disorders. The goal is not just memorization, but understanding how to recognize MS confidently in real clinical scenarios. Here's our roadmap. We'll begin by establishing the disease foundation, what MS actually is, why it happens, and who it affects. Then we'll move into clinical presentation because recognizing classic symptom patterns is essential. After that, we'll cover investigations and diagnostic criteria, especially the updated McDonald criteria. We'll also discuss important mimics and red flags because misdiagnosis in neuroimmunology can have serious consequences. Finally, we'll cover management, prognosis, pregnancy considerations, and the high-yield exam facts that frequently appear in postgraduate assessments. Multiple sclerosis is a chronic immune-mediated inflammatory demyelinating disorder of the central nervous system. It primarily affects the brain, spinal cord, and optic nerves. Historically, MS was thought of mainly as a demyelinating disease, but modern understanding tells us that axonal injury is equally important, because this is what drives permanent neurological disability over time. Pathologically, three hallmarks define the disease: multifocal demyelination, oligodendrocyte loss, and reactive astrogliosis. Clinically, the core diagnostic principle is dissemination in space and dissemination in time. In simple terms, patients develop neurological episodes affecting different CNS regions at different points in time. From a pathophysiological perspective, MS has two overlapping phases. The early phase is predominantly inflammatory, where autoreactive T and B lymphocytes cross the blood-brain barrier, trigger cytokine release, recruit macrophages, and cause acute demyelination. The later phase becomes increasingly neurodegenerative, characterized by axonal loss, mitochondrial dysfunction, chronic microglial activation, and progression that may occur even without obvious relapses. This explains why some patients continue to deteriorate despite reduced inflammatory activity. The typical age of onset is between 20 and 40 years. There is a clear female predominance, with a female-to-male ratio of approximately 3:1, suggesting hormonal and immunological influences. Geographically, prevalence increases with latitude. This likely relates partly to sunlight exposure and vitamin D biology. Migration studies are particularly interesting. Individuals moving from high-risk to low-risk areas before puberty tend to adopt the lower risk, highlighting environmental influence during early immune development. Genetically, the strongest association is HLA-DRB115. However, genetics alone do not explain the disease. Even in monozygotic twins, concordance is only around 25 to 40%. Environmental triggers therefore play a crucial role. The strongest known environmental association is Epstein-Barr virus. Seroconversion dramatically increases risk. Other established contributors include vitamin D deficiency, cigarette smoking, and obesity, particularly during adolescence. So clinically, think of MS as the result of genetic susceptibility interacting with environmental immune triggers. MS presents across multiple neurological domains, which reflects the multifocal nature of CNS involvement. Visual symptoms are extremely common. Optic neuritis is a classic presentation, typically painful unilateral visual loss, often associated with color desaturation, especially reduced perception of red, and central scotoma. Diplopia may occur due to brainstem involvement. Sensory symptoms are also very common. Patients may describe numbness, tingling, altered sensation, or electric shock-like sensations down the spine with neck flexion, known as Lermit sign. Motor symptoms include weakness, spasticity, and profound fatigue, which can be disproportionately disabling. Uthoff phenomenon refers to transient worsening of symptoms with heat, exercise, or fever due to impaired conduction in demyelinated fibers. Trigeminal neuralgia in a young patient should also raise suspicion for MS. Cerebellar involvement may produce ataxia, intention tremor, anastagmus, and scanning speech. And autonomic dysfunction is common, especially bladder urgency, frequency, bowel dysfunction, and sexual dysfunction. The key exam principle is this: symptom patterns reflect lesion location. Now let's move to bedside examination. A relative afferent pupillary defect, or Marcus Gunn pupil, suggests optic nerve dysfunction, often from optic neuritis. This is tested using the swinging flashlight test. Internuclear ophthalmoplegia is another classic sign. Here, the affected eye cannot adduct properly, while the abducting eye develops nystagmus. This reflects a lesion in the medial longitudinal fasciculus. Bilateral internuclear ophthalmoplegia in a young adult is highly suggestive of MS. Upper motor neuron signs are common: hyperreflexia, sustained clonus, increased tone, and extensor plantar responses. Gait can also provide major clues. Patients may demonstrate spastic circumduction, toe drag, or wide-based ataxic gait, depending on corticospinal versus cerebellar involvement. And one particularly high-yield but less commonly discussed sign is McArdle's sign, rapid worsening of weakness or gait impairment with neck flexion. So when assessing suspected MS, careful neurological examination remains incredibly powerful. Multiple sclerosis is not a single uniform disease. Instead, it exists across several clinical subtypes, each with different trajectories and management implications. The first is clinically isolated syndrome, or CIS. This refers to a first demyelinating clinical event, such as optic neuritis, brainstem syndrome, or transverse myelitis, that is suggestive of MS but does not yet fulfill full diagnostic criteria. Some patients remain monophasic, while others progress to definite MS, depending on MRI and biomarker findings. The most common subtype is relapsing remitting MS, accounting for approximately 85% of initial presentations. This is characterized by clearly defined relapses, followed by periods of partial or complete recovery. Over time, many untreated patients transition into secondary progressive MS. Here, disability gradually accumulates independent of acute relapses. This diagnosis is often retrospective because the shift is gradual rather than sharply defined. Then we have primary progressive MS, which behaves differently. Instead of relapses, patients experience steady neurological deterioration from onset, often presenting as progressive myelopathy. This subtype represents around 10 to 15% of cases and notably has a near equal male to female ratio. Finally, radiologically isolated syndrome, or RIS, refers to incidental MRI findings typical of MS in patients without symptoms. Not all convert, but risk increases significantly if oligoclonal bands or spinal cord lesions are present. Understanding subtype matters because prognosis and treatment decisions depend heavily on disease phenotype. MRI is the gold standard imaging investigation in multiple sclerosis. A field strength of at least 1.5 Tesla is preferred for reliable lesion detection. The classic MRI appearance includes T2, or flare hyperintense lesions in characteristic locations. These include periventricular regions, cortical or juxtacortical areas, infratentorial structures such as the brainstem and cerebellum, and the spinal cord. One classic exam image is the Dawson finger appearance, ovoid lesions projecting perpendicular to the lateral ventricles, reflecting inflammation around medullary veins. Gadolinium enhancement indicates active inflammation and blood-brain barrier disruption. If both enhancing and non-enhancing lesions are present simultaneously, this can help demonstrate dissemination in time. T1 hypointense lesions, commonly called black holes, represent chronic axonal loss and therefore permanent tissue damage rather than transient inflammation. Newer imaging biomarkers are becoming increasingly important. The central vein sign helps distinguish inflammatory demyelination from vascular white matter disease. And paramagnetic rim lesions suggest chronic active inflammation. So, in exams and clinical practice, MRI pattern recognition is absolutely central. While MRI is the cornerstone of diagnosis, ancillary investigations provide crucial supporting evidence. In cerebrospinal fluid, oligoclonal bands remain one of the most important findings. If two or more bands are present in CSF but absent in serum, this indicates intrathecal immunoglobulin production. This strongly supports MS. Over 90% of patients with MS demonstrate oligoclonal bands. A newer biomarker gaining importance is the kappa free light chain index, which offers strong diagnostic performance and has now entered formal diagnostic frameworks. If MRI cannot fully clarify the diagnosis, electrophysiology may help. Visual evoked potentials assess conduction along the optic pathway. Delayed P100 latency suggests prior demyelination, even if the patient has no active visual symptoms. Optical coherence tomography is increasingly used to quantify retinal nerve fiber layer thinning, which reflects neuroaxonal injury following optic neuritis. The important exam concept is that diagnosis is never based on a single test. It's a synthesis of clinical pattern, imaging, and supportive biomarkers. The McDonald criteria remain the framework for diagnosing multiple sclerosis. But remember, these criteria should only be applied when clinical suspicion is appropriate. They are not intended to distinguish MS from every possible mimic. Diagnosis requires evidence of dissemination in space, meaning lesions affecting multiple CNS regions, and dissemination in time, meaning disease activity occurring at different time points. For dissemination in space, at least one T2 lesion must be present in at least two characteristic locations. Importantly, the optic nerve is now recognized as an independent topographic region in the 2024 update. The 5 regions are therefore optic nerve, periventricular, cortical or juxtacortical, infratentorial, and spinal cord. Dissemination in time can be demonstrated in several ways. A new lesion appearing on follow-up MRI. Simultaneous enhancing and non-enhancing lesions on one scan. Positive CSF oligoclonal bands, elevated kappa-free light chains, or a second clinical attack. The exam trap here is using outdated criteria. Know the optic nerve update. Before diagnosing MS, always consider mimics. Misdiagnosis can lead to inappropriate immunotherapy and significant harm. A major inflammatory mimic is neuromyelitis optica spectrum disorder, or NMOSD. Think of this when there is severe optic neuritis, longitudinally extensive transverse myelitis, or aquaporin 4 antibody positivity. MS therapies may actually worsen NMOSD. MOG antibody-associated disease, or MOGAD, is another critical differential. Patients often present with bilateral optic neuritis, optic disc swelling, or cortical syndromes. Acute disseminated encephalomyelitis, particularly in younger patients, tends to be monophasic, post-infectious, and associated with encephalopathy. Metabolic mimics include B12 deficiency causing subacute combined degeneration, which may resemble progressive myelopathy. Structural mimics include cervical spondylotic myelopathy. Red flags suggesting an alternative diagnosis include hyperacute onset, which points more toward vascular pathology. Persistent systemic symptoms such as fever, weight loss, or night sweats suggest inflammatory, infectious, or malignant causes. And bilateral simultaneous optic neuritis should immediately raise suspicion for NMOSD or MOGAD rather than classical MS. Management of acute relapse aims to accelerate recovery, not alter long-term disability. The first question is functional impact. If a patient has significant visual loss, motor weakness, or disabling neurological deficit, treatment is indicated. Mild purely sensory symptoms may sometimes be observed. First-line treatment is high-dose methylprednisolone, typically 1 gram daily, either intravenously or orally for 3 to 5 days. Steroids reduce blood-brain barrier permeability and suppress inflammation, helping recovery occur faster. However, they do not change the ultimate degree of neurological recovery. If symptoms remain severe despite steroids, second-line rescue therapy includes plasma exchange or immunosuppression. Alongside relapse treatment, symptom control is crucial. Fatigue may be managed with amantadine or occasionally modafinil. Spasticity responds well to baclofen as first-line therapy. Neuropathic pain can be treated with gabapentin or pregabalin, and gait dysfunction may improve with dalfampridine, a potassium channel blocker that enhances conduction in demyelinated axons. This is where management becomes truly multidisciplinary. Now let's move into disease-modifying therapy, which is one of the most rapidly evolving areas in multiple sclerosis care. These treatments do not simply treat relapses, they reduce future inflammatory disease activity and slow disability progression. Traditionally, lower efficacy platform therapies included interferon beta and glatiramer acetate. These have extensive long-term safety data and remain useful in selected patients, particularly when safety is prioritized. However, they are less potent than modern agents. Among oral therapies, dimethyl fumarate is commonly used but requires monitoring for gastrointestinal intolerance and lymphopenia. Teriflunomide is another oral option, but a major exam point is teratogenicity. Because of its long persistence in the body, accelerated elimination with cholestyramine is required before conception. The S1P receptor modulators, including fingolimod and siponimod, are more effective, but come with important monitoring requirements. Fingolimod can cause bradycardia, particularly after the first dose, so cardiac monitoring is essential. Macular edema is another recognized complication. Siponimod is particularly relevant because it is approved for active secondary progressive disease. Across this drug class, routine monitoring includes blood counts, liver function, ophthalmology surveillance where relevant, and infection risk assessment. Modern MS management increasingly favors earlier use of high-efficacy therapies in appropriate patients. This reflects the concept of preventing irreversible neuroaxonal damage before disability accumulates. Anti-CD20 therapies, including ocrelizumab, ofatumumab, and rituximab, are highly effective at suppressing inflammatory disease activity. Ocrelizumab is especially important because it was the first approved therapy for primary progressive MS. Natalizumab is another highly effective agent, particularly in aggressive relapsing disease. However, the major concern is progressive multifocal leukoencephalopathy, or PML, due to JC virus reactivation. This makes JCV antibody monitoring essential. Cladribine offers an immune reconstitution approach through pulsed oral therapy, but lymphopenia remains an important safety issue. Alemtuzumab is highly potent but comes with significant risks, especially secondary autoimmunity, including thyroid disease and immune thrombocytopenia. One key modern principle is the shift away from purely stepwise escalation. For highly active disease, many centers now favor a hit-hard early strategy, using higher efficacy therapies sooner. Pregnancy planning is an essential part of MS management, particularly given the young age of many patients. Reassuringly, MS itself does not impair fertility, increase miscarriage risk, or usually worsen fetal outcomes. However, disease-modifying therapies require careful planning. The safer options include interferons and glatiramer acetate. Teriflunomide is absolutely contraindicated due to teratogenicity and requires formal washout before conception. Some highly active patients may remain on natalizumab depending on individual risk assessment. Interestingly, relapse activity naturally decreases during pregnancy, particularly in the third trimester. This reflects the immunological shift toward fetal tolerance. However, the postpartum period is the major danger window. Relapse rates rise significantly in the first 3 months after delivery. That makes postpartum treatment planning critical. MRI without gadolinium is generally considered safe if imaging is necessary, but gadolinium contrast is typically avoided. For exams, the classic teaching point is simple. Pregnancy protects temporarily, postpartum rebounds. MS prognosis varies widely between patients. Some remain relatively stable for years, while others accumulate disability more rapidly. Favorable prognostic factors include younger age at onset, female sex, relapsing remitting disease, sensory or optic neuritis presentations, low MRI lesion burden, and complete recovery from the first relapse. Poor prognostic indicators include older age, male sex, high early relapse frequency, spinal cord or brainstem involvement, heavy baseline lesion burden, and incomplete recovery after relapse. Primary progressive disease generally carries a less favorable trajectory. Historically, the term benign MS has been used for patients with minimal disability after many years, though this label is increasingly debated. In terms of disability scoring, the Expanded Disability Status Scale, or EDSS, remains widely used. An EDSS of 6 is an important clinical milestone because it indicates the need for unilateral walking assistance. Increasingly, biomarkers such as serum neurofilament light chain may help monitor neurodegeneration and prognosis. Let's finish with the high-yield facts examiners love. Uthoff phenomenon refers to transient worsening of neurological symptoms with heat due to impaired conduction in demyelinated axons. The 2024 McDonald update. The optic nerve is now a formal independent region for dissemination in space. Black holes on T1 MRI indicate permanent axonal damage, not transient edema. Primary progressive MS is unique because it presents with steady progression from onset and has a roughly equal male-to-female ratio. Dalfampridine improves walking by blocking potassium channels and improving conduction. Natalizumab and PML, always remember JCV monitoring. Bilateral internuclear ophthalmoplegia in a young adult should strongly suggest MS. Teriflunomide is teratogenic and requires accelerated elimination before pregnancy. Kappa-free light chains are increasingly important biomarkers in updated diagnostic frameworks. And finally, remember that radiologically isolated syndrome can convert to clinical MS, especially when oligoclonal bands or spinal cord lesions are present. The key message from this entire topic is this. Multiple sclerosis is a disease of pattern recognition, clinical localization, characteristic imaging, appropriate biomarkers, and careful exclusion of mimics. Master those principles, and the diagnosis becomes far clearer